Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me. This patient had a motor vehicle accident with airbag deployment. Her face struck the airbag and it caused a traumatic dislocation of her lens. You're going to see me using triamcinolone to visualize vitreous, carefully bisecting the lens using micro instruments, performing a thorough anterior vitrectomy, and then doing my modified Yamane technique using the trailing haptic first technique, making sure I mark the conjunctiva and controlling the eye so that the conjunctival marks reflect the scleral marks that I need to use, as well as straightening out the haptic along the bevel of the needle technique. And so you can see the eye here, you can see the stria in the capsular bag. The capsular bag is completely torn, and you can see the haptic is within the anterior chamber as shown here. And so I'm using a cotton tip to turn the eye, and then using the back of the trocar to mark 4 millimeters posterior to the limbus. I'm holding the eye, and about 3 millimeters away, I'm tunneling through the sclera with the trocar, tunneling, turning near perpendicular, and then diving in. And this creates a nice self-sealing incision. I'm holding the eye with forceps, and using the tip of a cannula that's marked with ink, I'm marking the limbus. Using the cannula, I'm trying to find 180 degrees apart, and it helps to go out. So decreasing the magnification really helps with making sure that you're correctly oriented. And so that's 180 degrees back. And then with the caliper set at 2.5 millimeters posterior to the limbus, I'm indenting the sclera and then marking, again, 2.5 millimeters posterior to the limbus on each side. Again, making sure the marks are 180 degrees apart. Once these marks are made, I'm going to mark about 2 millimeters adjacent to this mark. And that is going to be the starting point for the needle placement. I make my incisions. And this incision is going to be for the leading haptic to be externalized. I'm injecting intracameral lidocaine, and this is my incision for my anterior chamber maintainer. That's a 20 gauge Lewicki AC maintainer. I'm injecting some intracameral triamcinolone. And then I'm using the vitrector to remove the bubbles and to see if there's any vitreous. And there is no vitreous in the anterior chamber yet. So I'm injecting some dispersive viscoelastic to coat the corneal endothelium and fill the anterior chamber. And this is a 3 millimeter blade. I'm going to do a triplanar corneal incision, make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. With the teeth closed, I use the scissors to lift the edge of the optic, and then I'm able to grasp it with the forceps in my left hand. And I open up the teeth of the scissors so that it kind of supports the lens and lifts it up, and then I'm able to re-grab with the forceps. Now I'm able to cut the lens with the scissors completely in half. Take the scissors out, and then I'm going to grab a second set of forceps while still holding the lens piece with my left hand. I grasp the haptic, pull it out of the eye, and then grasp the rest of the optic. And I found this is really the easiest way to remove that first piece. And using a two-handed technique, I'm grasping this second half of the lens, and then as I pull it out, I make sure I protect the cornea with the other forceps. And here I'm going to do my vitrectomy. And again, like I said, I did not have any vitreous in the anterior chamber, but I knew there was going to be vitreous because the capsular bag was broken. I've increased the speed just because it's just going to be a long process. And that's the key. This is 8x speed, but the point is you need to do an extensive vitrectomy. And as I do this, you can see there's a lot of vitreous that's coming out as I do this. I'm using a cannula to sweep the main incision, and as I do this, you do see some vitreous at the edge of the incision, and I'm doing the vitrectomy of the vitreous in this area. So then I do some more vitrectomy from the limbal incision here, And I can see, I think there's some remnants of vitreous, and so I'm just using the cannula to kind of encourage the vitreous to go towards the cutter. So again, I continue to sweep. And now I'm going in through the main incision and sweeping my paracentesis because I did see some vitreous there. So you can see it's a little bit of an awkward position, but I'm able to go through the main incision and sweep the left side incision. I inject some more intracameral triamcinolone, and as you can see here, thankfully there is no more vitreous in the anterior chamber. So this will be the vitrector-assisted peripheral iridectomy. This is the patient's left eye. I'm coming through with a nasal incision, and I'm going to do a temporal iridectomy. So this is a fixed 30 cut rate, as well as aspiration flow rate 0 to 12, linear control, and vacuum with linear control from 0 to 350. So the port is down. I have the port down. I'm increasing vacuum, getting occlusion, and then I begin to cut, and you're able to get a really nice round and peripheral iridectomy. I'm going to place my injector, and my assistant is delivering the lens. I'm using my left hand with the microforceps to pull the leading haptic out of the eye. Once the leading haptic is out of the eye, I take over and I start to turn the injector so that the lens starts to deliver. In this way, I have more control, making sure that that leading haptic is still outside of the eye and the optic is coming out correctly. Once the trailing haptic comes out, I sweep it to the right, and then I coat the cornea more with dispersive viscoelastic. This is going to be the right side needle. I'm bending it about 9 millimeters from the tip and about 70 degrees, and I'm making sure that the bevel is going to face towards the haptic. This is the left side needle. I'm bending it at the hub, and again, it's going to be facing towards the haptic. I'm placing the trailing haptic through the incision in a U-shaped configuration. I'm going to grasp the trocar with my left hand, tunneling with the needle on my right hand. Again, I'm 2.5 millimeters posterior to the limbus. I tunnel 2 millimeters and then dive into the vitreous space. Using microforceps, I'm going to cannulate the needle with the haptic. So again, the bend of the needle is towards me. I place the haptic on the bevel of the needle and it slides in very nicely. I disengage my syringe from the needle, and then with microforceps I internalize the leading haptic, place it in the angle, hold the wound with the forceps. The needle is going to go in from that mark, again 2.5 millimeters posterior to the limbus, tunnel 2 millimeters, and then dive in to the vitreous space. Again, the bevel faces the approach of the haptic. Again, the haptic is curved, and so you have to flatten it out in order to get it into the needle. You can see this. Even though I'm holding it far away, I'm able to straighten it out on the bevel of the needle, docking it, and then it's able to slide in very nicely, and then you internalize it even more. So I'm going to pull this needle out, and then very carefully with the forceps holding it to make sure not too much of the haptic is externalized, and then I cauterize it to create a small little bulb. You want to push the haptic further in because as you pull out the right side needle, you don't want to cause too much tension on the haptics. So as I pull out the right side needle, I have my forceps ready to retrieve it, making sure it's not externalized too much because that does cause tension on the haptics. And then I cauterize it to create a small bulb. Again, I'm using forceps to push it flush to the sclera, and then reapproximating and covering the conjunctiva over the haptic here. I'm going to go ahead and use mechanical irrigation and aspiration. Because I did such a thorough anterior vitrectomy, you'll see that I'm able to get away with doing mechanical INA in this case, and I don't encounter any vitreous. And so I think that's the key, is that anterior vitrectomy has to be really solid. So I'm going to go ahead and close the wound. Again, this is 8x speed. I always close the main incision when I do these cases because you really just don't want to take a chance, especially if there's vitreous or iris to the wound. It really is just not a good look. So I make sure I do more vitrectomy and inject some more triamcinolone just to be on the safe side. And thankfully, again, there's no vitreous throughout this part of the case. Go ahead and seal my incisions. When I pull the trocar out, you want to massage the sclera really nicely, and you can see that it self-sealed really well. I pull the AC maintainer out and then hydrate my incisions. So again, this is a patient who had a dislocated IOL. I did a kind of very careful bisection of the lens using triamcinolone to visualize vitreous, very carefully doing the modified Yamane technique, externalizing the leading haptic, which makes the trailing haptic a lot easier to do, making my marks 2.5 millimeters back and 2 millimeters adjacent, holding the eye in such a way that the conjunctival marks will reflect the scleral marks the way I want them to be, and this reduces the chances for tilt or a poorly positioned lens. I bent my needles in such a way that the bevel faces the approach of the haptic. And why is that? Because the haptic is curved and the needle is straight. So you want to dock the haptic on the bevel of the needle. And once you dock it, you can flatten it out and then it goes in very, very nicely. So at the end of the case, I'm injecting some subconjunctival lidocaine as well as some subconjunctival Ancef. And this is the end of the case. So I hope this was helpful to you, and I thank you for your attention.